Welcome to The Explainer. Today, we're diving into the fascinating and, honestly, kind of counterintuitive world of clinical testing math. We're going to discover exactly why you absolutely cannot always trust a positive test result. Yeah, even from a test you thought was incredibly reliable. Let's get into it.
So the core problem we face in medicine every single day is basically this. Why does a highly specific diagnostic test that works perfectly in a specialized high-risk clinic suddenly become terrible at its job when you use it as a broad screening tool for the general public? Seriously, why does a good test suddenly go bad?
Well, to map out exactly why this happens, we're going to cover 1. The diagnostic dilemma, 2. The prevalence trap, 3. Fusing sensitivity and specificity, 4. The power of likelihood ratios, 5. Shifting post-test probabilities, and 6. The ultimate exam metric.
Starting with Part 1, the diagnostic dilemma, predictive values.
You know, the clinical utility of a diagnostic test really often centers on predictive values. Why? Because they directly answer the patient's biggest question, which is regarding the probability that their test result actually matches reality. Positive predictive value determines the likelihood that a patient with a positive test truly has the disease. On a flip side, negative predictive value determines the likelihood that a patient with a negative test is truly healthy. It sounds super straightforward, right?
But here's the fundamental limitation of predictive values for broad clinical application. It's their absolute dependence on population prevalence. If a clinician applies a highly specific diagnostic test to a high-risk population, say in a specialized tertiary care clinic, the positive predictive value will be exceptionally high. But if that exact same test is deployed as a screening tool for the general public, where the disease is rare, the positive predictive value will absolutely plummet.
Which brings us to Part 2, the prevalence trap, overwhelmed by false positives.
This is exactly where so many diagnostic errors happen. Prevalence dependence means your PPV is essentially a combined metric. It shifts purely on how common the disease is in the specific population you're testing. So, high prevalence equals a high PPV, but low prevalence, your PPV drops like a rock. And this is exactly why it plummets. When a disease is rare in the general public, the absolute number of healthy people taking the test is just enormous. Because of that, the absolute number of false positives will heavily outnumber the true positives. Your test gets completely overwhelmed by false alarms, which totally tanks the positive predictive value.
Let's look at Part 3, fusing sensitivity and specificity, the fixed properties.
To overcome the flaws of prevalence dependence, advanced clinical reasoning relies on the inherent unchangeable properties of the test itself. Before we even order a test, we care about two things. First, its sensitivity, the test's ability to identify true positives and catch the disease. Second, its specificity, the ability to identify true negatives and confirm it.
Think about it like a giant overlapping puzzle of healthy and diseased patients. By adjusting the diagnostic cutoff line, you can alter a test's sensitivity and specificity. But, and this is crucial, once that cutoff is fixed by the lab, those properties are locked in. They literally do not change just because you move the test to a different hospital.
As this quote perfectly highlights, the true beauty of these metrics is that sensitivity and specificity are completely immune to the prevalence trap. They are fixed, integral features. A test that is 90% sensitive is going to be 90% sensitive, whether you're evaluating a high-risk patient in the ICU or a random person walking down the street.
All right, Part 4, the power of likelihood ratios, the immutable solution. So, advanced clinical reasoning relies on likelihood ratios. These ratios represent a pure fusion of a test's inherent sensitivity and specificity. Let's break down the math real quick. The positive likelihood ratio is calculated by dividing the true positive rate, or sensitivity, by the false positive rate, which is 1 minus specificity. Meanwhile, the negative likelihood ratio is calculated by dividing the false negative rate, which is 1 minus sensitivity, by the true negative rate, or specificity.
Now, why is that formula a real game changer? Because sensitivity and specificity are fixed, immutable properties of the test itself, the resulting likelihood ratios do not change when the test is moved between populations of varying disease frequencies. They remain completely unbothered by shifts in disease prevalence, allowing a physician to apply the exact same mathematical weight regardless of the clinical setting.
Moving on to Part 5, shifting post-test probabilities, the clinical application.
Okay, so how do we actually use this stuff in the real world? Well, likelihood ratios are used to convert a patient's pretest probability of having a disease directly into a post-test probability after the result is obtained. This is a process frequently visualized using a Fagan nomogram. You assess the baseline risk, apply the likelihood ratio, and boom, you get your true post-test probability.
Let's put this into perspective with some benchmark numbers. A likelihood ratio of exactly 1.0 signifies that the test provides absolutely zero clinical information. Literally nothing. It leaves the post-test probability completely identical to the pre-test probability.
On the other hand, a positive likelihood ratio greater than 10? That indicates an exceptionally powerful test that causes a massive, clinically significant spike in post-test probability, effectively confirming a diagnosis. That's what you want to see.
Conversely, a negative likelihood ratio less than 0.1 indicates an excellent screening tool that drives the post-test probability down close to zero, safely ruling out the condition.
Finally, Part 6, the ultimate exam metric, taking it to the boards.
If you're prepping for medical boards, test writers will deliberately try to trick you with this concept. They'll move a test between populations and wait for you to assume the positive predictive value stays the same. But remember, PPV varies directly with disease prevalence. Don't fall for it.
On examinations, when asked to choose the best metric to evaluate a test's diagnostic power across multiple distinct clinics with different disease rates, the clinician must always select likelihood ratios over predictive values. Always. It is your mathematically stable anchor.
The math behind all of this is absolutely fascinating, but it really makes you wonder, doesn't it? With so much widespread testing happening globally today, how often is the medical system blindly falling into the prevalence trap without even realizing it? Next time you see a positive test result, ask yourself, what is the true mathematical weight behind this diagnosis? Thanks for joining me on this explainer. I really hope this changes how you look at clinical data. Catch you next time.